This is the Medtronic Dragonfly single operator cholangioscope, and there is some design features that were specifically incorporated to make this a more functional cholangioscope. It has a 1.7 millimeter working channel. With a larger working channel, we can actually use a larger diameter EHL probe, and that's more durable and more powerful than the thinner, smaller EHL probes. The second aspect of that is that we can use larger biopsy forceps than we could with the smaller channel, and that's been shown to yield a significantly larger specimen. It's a different design, but the design was made to increase functionality and ease of usability.
I'm Francisco. I'm Director of Global Marketing Therapeutic Endoscopy for Medtronic. Before we start, I want to thank and congratulate Dr. V and Dr. Haas and the entire Orlando Health team for such a fantastic course. Each year we leave this meeting thinking that this was the best meeting ever, but somehow every new year you are able to surprise us with an even better meeting. So congratulations again. If any of you haven't registered or haven't made plans yet to come next year, I invite you to do so. I think this will be the more than just a meeting. It will be a celebration of past, present, and future of endoscopy. But most of all, it will be a generational event you won't want to miss. So with that, it is with great pleasure that I welcome you to the Medtronic Launch Symposium, getting to the Holy Grail, establishing diagnosis in biliary strictures. On this session, we have a panel of well-recognized experts. Dr. Thorsten Beiner, Head of Internal Medicine, Gastroenterology, and Therapeutic Endoscopy at Evangelist Krankenhaus Düsseldorf in Germany. Dr. Jayan Baradrajulu, President, Orlando Health Digestive Health Institute in Orlando, also Professor of Medicine at the University of Central Florida. And finally, Dr. Neeraj Jala, Chief Oncologic Pathology at Rutgers Cancer Institute of New Jersey, Professor and Vice Chair of Clinical Operations at Rutgers Robert Wood Johnson University Hospital. Without further ado, I pass it to you, Dr. Haas, to moderate this session. Thank you very much.
Thank you, Francisco, and thanks again for sponsoring this. It's my pleasure now to welcome to the podium Thorsten Beiner. We've introduced him before. He's one of the young superstars of our current generation. So welcome, Thorsten.
Yeah, Rob, thank you very much for this kind introduction and also for inviting me again to this wonderful meeting. It's, as I said before, I feel really at home being here. So, and also thank you to Medtronic for hosting this satellite symposium. So let's find the Holy Grail. Neoplastic biliary obstruction, when to perform EUS, FNB, or single operator cholangioscopy guided biopsies. So what's the role of endoscopic tissue acquisition and drainage in the management of malignant biliary obstruction? First of all, we have to select the patients according to several criteria, in particular the oncological concept, if it's curative or palliation. Then we have to take into account the location of the lesion. If it's proximal hilar stricture or distal stricture, then we can decide which method we use for sampling, ERCP versus EUS, and today less important the method for drainage. If we go for cannulation with ERCP or S-guided drainage, and then we have to select this type of stents and the implantation technique. Let's start with a short case first. So here we have the CT scan. You can nicely see here the dilated bile ducts, and we can see this very small mass just on top of the pancreas here. So first of all, here I performed an EUS. We found this very small mass here, located just above the pancreas. And so this was longitudinal EUS. We could have done the biopsy here, what I didn't do. But let's go a step further, and then we can see what I did here. So this is the new ESG guideline, how to manage biliary strictures, and I just want to show you. So of course we have to decide if it's a proximal stricture or distal. If we have a proximal stricture, we have to decide if the patient needs drainage. If you have to drain the patients, then of course we will go for ERCP and tissue sampling with ERCP techniques. If not, we can decide if the patient should receive surgery as a first-line approach. And if we have a distal tumor, of course, again, is the question, drainage needed or not. If drainage is needed, we can combine ERCP, but also EUS tissue acquisition. And if not, it's also an option to go for primary surgery. But if we go for histopathology or for sampling, then we would use EUS tissue acquisition here. So this is what I did here. In this case, no EUS biopsy, but the patient needed drainage, and of course we're doing here direct cholangioscopy. Here we can see, okay, I skipped this difficult cannulation in this case, just to show you here the stricture. We can see here concentric stricture, we can see dilated vessels, irregular surface structure, and of course we take biopsies that we can obtain here under direct vision, and we can jump a little bit. Okay, sorry. Wanted to make it a little bit shorter, the video. Okay, this is how it goes, okay. Okay, then we have to watch the video. I cannot jump forward here. Yes, thank you. Okay, now we are already in the stricture. Within the stricture, you can nicely see dilated vessels. That is always a good indicator for malignant infiltration. But we could also pass here the stricture and, of course, see the hilum that was not involved here. So pass a little bit further. Let's see if this works. Okay, we are here in the hilum. So after that, the biopsies proved adenocarcinoma here in this patient, and finally we put in a stent because the patient needed drainage beforehand. Here we see the plastic stent implantation. We could have gone also for a fully covered metal stent, but here the stricture was located at the cystic duct junction. There was a high risk of obstructing the cystic duct here. So what's the problem with the optical diagnosis? It is that we have different opinions also among experts. So the inter-observer agreement also in this European study is inter-observer agreement for optical diagnosis. It's not ideal. Here in this case it was just fair. So we still depend on classification systems. We have a couple of classification systems for these strictures. We have this Monaco criteria. We have also the Mendoza criteria that are quite well accepted. But still it is difficult to establish a diagnosis just on optical or your visual impression. Also this is difficult in the tumor board. So we depend on tissue. And we still know, and this is one example of our randomized trial, that cholangioscopy-guided biopsies are superior to biopsies or brushing cytology done with standard ERCP technique. However, their sensitivity around 70%, a little bit better, is still not ideal, I guess, to obtain here tissue diagnosis. So in this context, we need improvement in our technology. And here comes the new Medtronic Dragonfly cholangioscopy platform. You have seen this nice video in the beginning. So we have an improved design. It's very ergonomic, and you have a very predictable tip maneuverability. It's more or less one-to-one tip deflection, 360 rotation capability, and you have a very large 1.7 millimeter working channel. So unfortunately, Dragonfly is not approved in Europe yet, so I have to depend on the opinion of the local masters in endoscopy, of course. But luckily, I got these videos from Dr. Shah, also from Medtronic here, that I can show you what is the performance of this new platform. You can see here on the right-hand side, we have a very large working channel that can harbor also this very large EHL probe. So here the Dragonfly First of all, please recognize the very good image quality, the good illumination in the near field and the distance. And here in this context, size does matter. So the large EHL probe is able to fragment this stone very effectively and quickly. So, and in terms of diagnosis of the malignant stricture here, there is also a novel rotatable biopsy forceps, 1.5 millimeter diameter, and also with a diameter of the branches of 6 millimeter, you can obtain really good biopsies here from the tumor site, and that helps a lot. So let's go back a little bit to the distal obstruction. Here, of course, we can go for EUS tissue acquisition. You have seen that during the morning in a couple of cases. If the patient needs drainage, of course, you can do ESCP, but then you go for EUS. If the patient doesn't need surgery as a first-line approach. So we have a couple of needle designs available. Nowadays, it's more or less always front-cutting needles. What is the challenge for the needles? Of course, we need high cellular samples for additional and also molecular studies. Of course, we want to achieve a high diagnostic accuracy. For some hospitals, ROSE is not available, so we would like to get rid of ROSE. We don't want to perform special collection methods, and of course, we would like to have a high diagnostic accuracy in one single pass. So luckily we have data from the Orlando group showing us very clearly that the technique using the novel needle designs, Francine type and also fork type needle like the Charcot needle, using styloid retraction or no suction technique is very effective. And in the end, if we compare all the different needle types with a single pass, it turns out that here the fork-tipped needle of the Charcot needle seems to be the best design you can use. So let's have a quick look. Of course, we have seen that during the morning, and we'll see that in the afternoon session nicely. So we can perform here the EUS FNB using the novel needle design. You puncture the lesion and then you try to reach a couple different regions within this lesion, and then you can obtain this very nice specimen to make the diagnosis. We need this. So our oncologists always say we are living in the era of the precision oncology, and this is what we need. So we need very good samples, histopathology for molecular profiling, and also for a couple of other things to make the ideal individual plan for our patients. So in summary, I think the visual diagnosis is, including also cross-sectional imaging, is often not sufficient to make the diagnosis. And in many patients, tissue acquisition is needed for proving neoplastic biliary obstruction. That then depends in the end on the oncological concept, the location, the growth pattern, and also if there's a need for biliary decompression. Proximal, go for ESCP, cholangioscopy. Don't perform EUS if the patient is a surgical candidate. Don't perform EUS FNB there. In distal obstruction, EUS tissue acquisition is first-line approach, and the best histopathology, and we should go for that nowadays, can be achieved with front-cutting needles preferred over cytology. Thank you very much for your kind attention. And I would like to invite all of you, if you want to go to Europe, please come to the Düsseldorf International Endoscopy Symposium. It will be 28th next year again, and some of the local faculty members you will meet there as well. So thank you.
So I want to thank Medtronic for supporting this symposium. I chose biliary strictures because this is a problem for us. These biliary strictures are, we are not excellent with ERCP, and by EUS also we are not very good. And at best we can reach a diagnostic accuracy of about 75%. And time and again we still see these cases. Occasionally we thought benign will come later down the line with an isolated met to the liver, and then you feel bad about it. This talk is going to be purely practical and less didactic. So there are 3 pictures, and these were my days in Birmingham, and I called all 3 of them wrong. The first picture on your left, you can see a stricture right there. I sent this to a surgeon. He's a very, very good transplant surgeon. He agreed, he operated, and that happened to be autoimmune cholangiopathy. There was no cancer. This patient is from Mary Hahn, who's now the chair of surgery at Stanford. So she did a lap chole, and it was a little bit of a complication. I did an EUS and an ERCP, and I was fairly convinced that this was a laparoscopic cholecystectomy-induced biliary stricture. After 2 years, the patient came to me with multiple liver mets. This patient was again a patient who came to me with obstructive jaundice. This was in the early 2000s. I convinced John Christine, who was a fantastic surgeon, to operate. He did a Whipple, and this became the new diagnosis of autoimmune pancreatitis that was gradually being recognized. So I got all three of them wrong. But if you look at the data, and if you go back and read the literature, EUS FNA will get you a diagnosis 75% of the time in a biliary stricture, whether proximal or distal. It will preclude the need for cholangioscopy, which is technically a little bit more difficult in about 60% of patients. So in 40% of the cases, when you have a biliary stricture, particularly from the mid-CBD to the proximal bile duct and beyond, you will require single operator cholangioscopy. There are a few practical considerations. This is very, very important because I have reviewed a lawsuit for this. Patient goes to the doctor and then they performed a EUS guided FNA, and then that precluded a liver transplant, and then the patient wanted to sue the physician who did the FNA. So these are some clear things, because there is one paper that came out from the Mayo Clinic that tells you that if you have got, where they compared two groups of patients, those who underwent EUS guided biopsy of a biliary mass versus ERCP. And what they found is when you do perform EUS guided sampling, you can cause seeding, and these patients later down the line had peritoneal carcinomatosis, and therefore that's a recommendation to be careful. So then who are the patients in whom with a biliary stricture you should perform a FNA or FNB? If somebody's got an advanced cancer, then of course it's a no-brainer. It's a metastatic cancer, inoperable, you can biopsy them. High-risk patients for surgery, they are referred directly by the surgeon who tells you, we're not going to operate on this. Can you biopsy them? Sure, we can do an EUS. If the patient is going to send by an oncologist to you, already determined to have chemotherapy radiation, sure, it's a palliative option. We don't have to worry about anything. And finally, if it is referred by a transplant surgeon, absolutely, we can perform an FNA because we know that the referral tract is clear. I'm going to show you a couple of masses that came to me a second or third opinion EUS to tell you how you can find your liver mass. So this is a patient with a mass in the liver hilum. You advance a scope into the duodenal bulb with a linear scope. You find the portal vein, the pancreatic duct, and the bile duct. In an anti-clockwise direction, by turning to the left, you have to trace the bile duct. It's a small bile duct, and then it traced and landed in this mass, right? So this is a bile duct that became the hepatic duct, and you find the mass. The scope should be in the long scope position. If you are in a short scope position, you're going to fall down. So you have to be locked into the duodenum in a long scope, and that will enable the needle not to get hung up on an elevator, and you'll be able to get that needle into the mass without any problem. So long scope position is the trick for a hilar mass lesion. And then you can see subsequently you do an ERCP to prove that this is a hilar mass, and you have a cholangiogram, and you can see that this is a proximal bile duct lesion. This is very easy if the mass is more than 2 centimeters and above. If it's a smaller mass, it can be a little tricky. So we will now go to the next patient. This is not a hilar mass. This is a proximal bile duct mass. And there's a second way of finding these lesions. What you do is you go into the duodenal bulb, and then you look at the liver. And once you find the liver, you have to torque the scope, and now you're going downwards. I showed you should trace the bile duct top, but now I'm going to show you the common bile duct and hepatic duct, and you trace it towards the papilla, which means an opposite motion of clockwise instead of anti-clockwise. You now turn your scope on the right side, and then you trace these dilated duct. You keep going down towards the ampulla on the right side. You're still in the bulb, and then you will find the right duct, the left duct, and you will come into the communication with the mass. It was approximately an 18 millimeter mass. It's very important for you to tell your assistant to hold the scope, because you will have the intervening portal vein in this area. So you don't want to puncture the portal vein. You find this mass here, right? And then I think it is, right by the wall of it. And then you make some small motion. It's about maybe at best about 10, 12 millimeters. And then here, if you're not sure about cannulation, try avoiding an FNB needle. Occasionally, FNB needles are great. FNA needle will cause less of a bile leak because the mass will have surrounding inflammatory reaction, so it will not cause a bile leak. So you sample it, and then you can see on cholangiogram. So once again, the trick is you find the bile duct, and then you torque your scope clockwise to the right towards the papilla. You find the mass, you find the window, and then you sample it. So now let's go to the distal bile duct mass. These masses are quite easy because they are same as pancreatic cancer, but occasionally then they can be tricky. So this patient was referred to us as a second opinion from another facility, had multiple negative biopsies. There we go. So in this case, I can tell you that we performed an FNA and I was indeterminate. So I did an ERCP. I placed a stent after getting a very good cholangiogram. Now, I repeated the EUS in the same session. So I failed the EUS, I did an ERCP, I put in a stent, a plastic stent, and I'm coming back with an EUS. And fluoroscopy, make sure you leave enough contrast. See that? You will find that mass, and you will be able to get your needle directly along the stricture path. You got a nice distal and a proximal bile duct, and then you got the mass in between, and you go through it. Almost 100% of the time you will not go wrong if this is a cancer. You don't have to worry about bile leak because you've already decompressed the system. Don't put a metal stent. If you put a metal stent, then you're going to have a lot of reverberation. You won't be able to see it. You will find some plastic. So tell your pathologist not to worry too much about it. You might, nothing will happen. And this you can see, the pathology is very important for you to appreciate because, see that? Let me just show you that. You have a lot of normal ductal cells, see that? And you find very few cancer cells, and that's why this technique sometimes comes in handy. This is probably the most difficult one. So these are the patients who will be referred to you telling they came with a jaundice. It's papillary stenosis. This papillary stenosis is a funny diagnosis. You put in a stent, the jaundice disappears. You take the stent away, in 6 weeks, they come back with jaundice. Of course, you can have occasionally these papillary stenosis, but this, you can miss a distal small cholangioCA, particularly if you have a stent. And once your pathologist knows there was a stent before, they're very reluctant to give you a diagnosis of cancer. So there are a few technical things that are critical with these cases. So here you see a bile, you will find the bile duct, right? It's very, very small bile duct. It's not dilated. There's a stent inside. Now, you're going to the second portion of the duodenum. You have to shorten the scope. In this particular instance, you have to shorten the scope. You pull back, you find the bile duct. See that? This is the mass. It's hardly 8 millimeters. In this case, you have to go on the short scope because the short position, because it's uncinate. Here, to sample this lesion, the needle literally has to come at 180 degrees. Look at the plane of the angle. There's only one needle that comes at 90-degree angle. It is a 25 gauge FNA needle. Yeah, FNB 25 gauge will not come straight. Only an FNA needle. So it's preferable to have rows in this particular circumstance. Fortunately, we don't get many of these cases. But if you have a patient, distal cholangio, repeated biopsy is negative, it's possibly few millimeters. You put your cholangioscope, you're falling down because it's right above the papilla, and look at the number of cancer cells you have on a FNA sample. So your 22 gauge FNA short scope position, you have to come at 90 degrees. Then this, not uncommon. So you will find a patient in whom they saw a mass and they were so confident, they placed an uncovered metal stent. And there is no tissue diagnosis. So here you will have a lot of reverberation. So the important thing is this is fairly easy. All you do is you pass the scope, you see the air, and then what you do is you have to keep continuously torquing the metal stent with the metal stent in view. And you will find the mass lesion in a different plane of the angle. So the trick here is to move away from the reverberation and give a clockwise or an anti-clockwise torque, and then you will find the soft tissue density around the meshes of the stent. And then if you target it, more than likely you will have your diagnosis of whether it is benign or malignant. But this can be tricky, and you will see this once in a while where a metal stent is placed without a tissue diagnosis. So again, to just summarize it, you go to the duodenal bulb, you trace the common bile duct or the stent to the liver hilum, or you trace the intrahepatic duct to the common bile duct. And when you have a well-defined mass, use a biopsy needle. If you have a lymph node nearby, you can target that lymph node with a biopsy needle. Sometimes you will have an ill-defined area where the soft tissue density, you're not sure what it is. And the way you look at it is, you have to really look at the liver parenchyma, and then it becomes very hazy. These are the patients where you call us bile duct mass with invasion of the parenchyma. You can use an FNB needle. Be careful, if the duct is not dilated, you might cause a bile leak, and you have to stent them. If you're not sure and if you don't want to do ERCP in this case, then use a FNA needle. There is still a small finite role for FNAs in specific circumstances. If your bile duct wall is thickened, very thick, then you go on the plane of the needle, you can use anything. But if you're worried that you're going to go into the lumen again, then you have to use an FNA needle, preferably a 22 gauge FNA or a 25 gauge FNA. For small uncinate lesions like the video I showed, no needle will work except a 25 gauge FNA needle. These are things you might feel very complicated. Fortunately, you don't see this very often in your practice, but when you find this, keep your eyes, keep your mind open about using FNA needles for these cases. Other necessities, I think you have to give antibiotics in patients with obstructed duct. If a biliary stent, you have to place a biliary stent if you think you have gone through the duct, because I've had a few cases where patients will go to the recovery area and have severe abdominal pain and there's a bile leak. And if you're not sure what you're sampling and if you're finding this haziness with the parenchyma, then this is one of those circumstances where ROSE must be considered so that you're not performing unnecessary passes. Other advantages of EUS compared to single operator cholangioscopy, you can obviously look for things outside the bile duct naturally for lymph nodes and other local spread of disease. You can target extrinsic lesions. And finally, minimal ascites. Go after minimal ascites because it's very important. But make sure you tell your cytopathology people to spin the sample and to create a cell block out of that sample. They just can't take an aspirate and look under the microscope. You'll be very surprised. Peritoneal carcinomatosis very often can be diagnosed. But if you tap ascites, make sure you're giving them at least 5 cc's or more so that there is enough cells in that liquid concentrate to spin. And also, if the more hemorrhagic the fluid, more likely you will find cancer in them. And lastly, this is something that, if you can have the luxury of having a pathologist, we always have rows in our unit for all of our patients. So here you can see us with a lot of vasculature on the bile duct, and you're performing a biopsy of it. Then we usually process it like how we process your FNA sample. It's put on the slide. This is called touch imprint. You can't smear it because if you smear it, you will cause what I call a shear artifact, and everything will look like a cancer and it will be false positive. It's very often false positive in spyglass than on FNA. So do not smear it. And then if you just create a touch pump, you will find cancer. And we have shown that by using this in conjunction with single operator cholangioscopy, if you use on-site, you can reach a diagnostic accuracy of close to 90%. And I think if you're very good with EUS, indeterminate biliary strictures, you will be able to make a determination fairly accurate 80% of the time. 20% may not be possible, and you have to switch on to single operator cholangioscopy or get another opinion. So thank you.
So Cheyenne and Torsten are going to head off to the hospital to do the cases. And we have a third talk that will be coming from the care center by Dr. Jala. So, Dr. Jala?
Yes, I'm here. Okay. So I won't touch it anymore, but I think both thanks to the Medtronics for putting together the symposium, and thanks to you for moderating the session. I am very happy that I was not the first speaker on this one. You have two fantastic speakers who made my life very easy, and I won't have to go into the details of what everybody is looking for. My job is to make sure that how we maximize the yield and how we maximize the diagnostic material and what can we do once the tissue is given to pathologists. Now, as we heard, these are some of the common ways in which we obtain the bile duct samples. Could be the percutaneous transhepatic approach, which very seldom used. ERCP-guided sampling is more frequently utilized either with brushing or forceps. EUS we just heard, and EUS FNA is what I heard because of less tissue trauma, especially in the biliary area. So I prefer FNA over FNB in this particular location. And then we talked about the spy bite forceps. Now, for each one, how do we adequately process each sample type for analysis? And I think that would be very, very important, because this is where we can make or break, because this is a very precious sample. You don't get enough chances to go back and do things. So it is important that how we process each one to maximize the diagnostic possibilities. So if we talk about the ERCP related brushing, there are a number of different ways people have done that, and these are the two big ones that I have put in as the picture over here. One, you can smear everything on the glass slide. You can get the rows and you can say, okay, what about the second pass and the third pass, and we can look into those. Oftentimes, we do not get the rows. We just get everything placed in the liquid-based sample in the transport medium. It comes to us, and then we spin it down, make it concentrated, and we use the liquid-based sample. There are multiple different liquid-based samples that can be prepared. The one that we use at our location is thin prep, so everything comes in a cytolite medium. Or you can do it on cytospin sample. Both are equally fine and both will equally work. If you are doing the smearing, then it is important that not only do the rapid one, which is air dried, but also put the another slide in the alcohol fixed material, because alcohol fixed material will give you the nuclear details that you may not be able to get with the diff quick sample. So that's important to consider, especially for biliary tree. In addition, for each lesion, if the malignancy is a consideration, then a dedicated pass should be collected, and dedicated pass should be collected for the molecular testing medium, so RNA later or something like that. If you put it in the alcohol-based material, the DNA yield becomes lower. If you put it in the cytolite, the DNA yields become lower. So you have to figure out which material you are collecting for the molecular testing piece. So this is very important part for the therapeutic decision making. Every time we do have to make a cell block preparation. Not only it will give me the cytology sample, but cell blocks will give me the architecture as well. And it is stained with H&E, and that helps out a lot. If you have a good cell block, then you can perform the immunohistochemical stain fish, and you can also get some molecular testing done if the sample is enough with you. So this is the brushing piece. The same thing with forceps biopsy. When you have a forceps biopsy, you can put it on the formalin fixed tissue after doing the touch prep preparation. But I always say that instead of sending it to search path, oftentimes I have told that you can send it to cytology so that they can utilize the protocol that we use for cell block preparation. The reason I say that is because these are very small samples. And if you spin it down, you make a tight button and then make a cell block, you're still going to get the architecture that a surgical pathologist is going to get. But oftentimes there are cells that are seen in that medium that will be captured if you use the cell block preparation. So depending upon each institution and their protocols, things are different. But I prefer that for very small tissue samples, a cell block methodology is used, which will give you both architecture, H&E, it will give you everything that a search path biopsy will give you. We talk about the endoscopic fine needle aspiration. It was very well covered by both speakers, so I don't have to do a lot of talking on it. Most of the times I prefer rows to, when there is rows, less than 3 passes are important. Don't go anything beyond that, because most of the times you will get the diagnosis based on these 3 passes. Again, air-dried diff quick stain preparations or alcohol stained PAP material can be utilized for fine needle aspiration. Once you have the adequacy, at this point in time, I generally don't say that I want to give you the diagnosis on site. Oftentimes, if it is clear like what I'm putting up there is an adenocarcinoma, then I don't have a problem saying it. But for purposes of biliary tree, I often say adequate material present, and then I ask for the dedicated material for cell block and a dedicated pass for molecular testing separate. The reason I say that is because when you make a cell block, when you cut the section, you do 2 sections, and on a small tissue, there is a possibility that you will lose it. So it is better to have a separate pass dedicated for molecular testing, keep separate. The other part is that if I know that it was a tumor before, then on cell block, I need to tell my lab that I don't need any testing on it other than the first cut, and I want to send everything else for the ancillary testing and keep it there. So judicious use of even tissue utilization is very, very important for these. When there is no rows, oftentimes we have said that just put 3 passes in the medium and send it in a transport medium. The transport medium, as I said, you have to figure out which transport medium is utilized. I frequently say that if I'm not present there, then put it into a normal saline or normal salt kind of material, not into formalin. Once it goes in formalin, I lose control over certain aspects of it. So it is important which transport medium is utilized for transportation of fine needle aspirations. And as I said, always collect for dedicated passes for molecular testing, and it helps. Same thing with spy bite forceps. This is a histologic material, so put it in formalin. And if you give 3 different bites, that would be very helpful. Because oftentimes we miss out on one piece of it where there may be a lot of fibrosis, and there may be very few cells on the surface which will be captured if you increase the number of pieces that you give for analysis. This material is very good for performing immunohistochemistry, FISH, or molecular testing. One dedicated pass for molecular testing would be really good for this particular case. So the diagnostic performance, everybody has commented on it, and there have been a lot of meta-analyses have been performed, and we know that when we talk about bile duct brushing, cytopathologists are not that great in its sensitivity. And we heard why we are not very good with it, because there are a lot of other reactive conditions that may cause troubles. Specificity is very good because we don't want to call anything where we are not sure. The same thing with EUS FNA. The performance is very good. If you utilize certain pathway, then the performance approach is 90%. The specificity has been good in everyone's hand. And for the spy bite as well, the pool sensitivity is 60%, and the specificity approach is 100%. So, and everyone has commented on it, and there are a lot of publications that also talk about those things. So what are the challenges and advantages of each sample type? So when we talk about brushing, it's relative ease. You just put it into a transport medium, send it to us, and we will be fine. One important thing that even we are seeing everywhere is that if you make a smear out of it, then you should know what you are looking at it for. If you are doing an on-site evaluation, drying and complete drying is important. If you don't completely dry a cell, the staining is really bad, and then you won't be able to make the diagnosis even on a good sample that you may receive from the clinical team. I prefer liquid-based preparation because you just put everything into it and I will get a good cell type available to me. But if not, if you just smear it, make sure that if you have an alcohol-based preparation, you don't leave that specimen lying somewhere for 2 minutes and then put everything into alcohol or create a smear like that. If you need to put the smear, put it immediately in alcohol after making the smear. Don't wait. The review of nuclear details is good with Pap stain, as I told before, and it is very helpful in making the diagnosis and looking for the cytologic assessments. ROSE allows for appropriate triage of samples, but for the most part, I have seen that for ERCP brushing, you don't require a lot of triage of samples with this sample type. Cell block is very useful, and you can perform FISH and molecular testing from these samples. The challenges are, we just talked about it, right? That if there is a stent or a calculi, the cytomorphology becomes very challenging. Not that it is impossible, but it becomes very challenging for a cytologist because of the morphology that changes because of it. And as a result, it's a low sensitive test. Performing immunohistochemistry on scanned sample may not be adequate, and therefore it may not be an optimal sample type to get it. Since this is a surface that we are scratching, therefore, if you find an abnormal cell, it is difficult to distinguish a high-grade dysplasia from an invasive carcinoma because that's just the nature of the sample type. You are brushing it and you are not going into the depth to figure out whether it is cancer or not, or invasion or not. For EUS, FNA, FNB, we have gone through this throughout the program, so I don't have to go through this a lot. The principles remain the same, average of 3 passes. It is rapid, it is cost effective, it is real time, and you can make a cell block out of it, and you can perform FISH and molecular testing, and this is a very good sample. It can be done on the distal, but the proximal biliary epithelium is a little bit more challenging with this one. With EUS FNA, one has to also recognize that the tumors, especially cholangiocarcinomas, will have a lot of stroma-producing tumor, and therefore there may be less cells that may come on EUS FNA samples. So you have to be cognizant that you may not always get enough number of cells to make the diagnosis, but in right hands it has always worked. For spy bite, provides histopathology, and I think this is a very good sample to have if you have properly aligned tissue available to you. This is obtained under direct visualization and improves diagnosis, and I prefer 3 bites for getting the sample type. The challenges are that this sample is very, very small, and so we have to be very careful and judiciously use our immunohistochemical armamentarium. There may be a lot of stains we have, but 1 or 2 should be used, not more than that, otherwise we will lose the tissue. The embedding is also challenging because then becomes a tangential sectioning. And for the group here, this is really important for histopathologists because if it is a tangential section, there is a challenge to figure out whether this is invasion or not an invasion, and we will have to rely on different morphology pattern types to see whether it is invasive or not. And these samples show marked crush artifact and can lead to false negative diagnosis, and because of the same reasons. So this is when I ask that 2 sample types are better. So if you have a brushing and a spy bite, it helps. If you have FNA and a brushing, it helps. FNA and a spy bite helps. 2 different cell types is always complementary, and it will increase the yield of getting the diagnosis better. This is just one example of it, that the spy bite biopsy was done. A lot of fibrosis, inflammation, hemorrhage that was seen in the tissue. There were some abnormal cells, but because of the crushing artifact, we may not be able to call it as tumor what it needed to be. But on the brushing, when the cell block was performed, it was very clear that these are neoplastic cells, and the patient has carcinoma associated with it. So having 2 different cell types is complementary, and it helps improve the diagnostic accuracy. Oftentimes, we have to distinguish between reactive epithelium and the tumor, and immunohistochemical stains have helped. One can utilize S100P, SMAD4, P53, and IMP3 are some of the stains that can be utilized to sway the diagnosis one way or the other. Simultaneously, FISH probes can also be utilized, and there are 2 different FISH probes utilized. One is Eurovision, that was primarily used for urine cytology. It has CEP3717, so ERB2 and P53 are covered in that, and a locus-specific probe of P16 is also there with Eurovision. Something very similar is with the pancreaticobiliary FISH that started out at Mayo Clinic, and they have done a good job of recognizing that FISH material, FISH testing. So FISH is very, very useful and can be performed on the smears as well as on tissue sections, and that has helped a lot many times. And always in this day and age, we cannot get away from genomic testing. And for extrahepatic cholangiocarcinoma or extrahepatic bile duct carcinomas, KRAS, P53, SMAD4 have been very important. There have been a panel of genes, about 28 gene panel has been created or selected based on DNA and RNA fusion panels and has been named as BILI-seq, just like ThyroSeq and other seqs. BILI-seq has come through. Actionable mutations, there are therapies available for, is ALK4, NRG1, NTRK has a therapeutic offerings now, and ROS1. Same thing, if it is PALB2 mutation or BRCA1 mutation, it becomes a germline mutation, and we also have to look for the type of therapies that can be offered to the patients with germline mutation, but also patient counseling becomes important. So this is really, really important for all of us. But we do require some additional help in terms of specimen procurement. These are the currently available things and how we can maximize the sample type. But with that, thank you. We all have knowledge. We just have to figure out how we use it. And thank you so much.
Thank you very much, Neeraj. We really appreciate that. So in our continuing effort to prevent you guys from having any downtime whatsoever, we've picked up your lunch boxes and we expect you to stay in your seats as we're ready to do the next session.